Hello, everyone, and welcome for joining our webinar this morning. We are going to begin in a couple of minutes as everyone joins us today. Depending on where you are, I'm saying good morning or good afternoon. Again, I just want to thank everyone. And if you would take a moment right now to please introduce yourself. As we're waiting for others to join us, just please open the chat window. You can post your name or where you're located, your role, and the connection to this topic, and we'll get started shortly. We have a diverse group with us.
And I'll just add, I'm Susan Stellan. I'll introduce myself shortly, but just, wanted to mention we'll be using the chat today. So if you keep that chat box open, we'll be using that for some questions. But great to see where everybody's joining from. Lots of coverage around the country.
Yes, a very diverse group with us this morning, this afternoon. Oh, wonderful. Thank you for participating and sharing your location and your role in connection to this topic. Susan, if you can go to the please.
Yeah, so maybe we'll flip back to this one and then I'll advance. If you want to introduce the topic and then I'll flip to the.
Sure. So again, welcome everyone to our webinar this morning, this afternoon, or today, depending where you're joining us. Current substance use trends and evolving risks. Our webinar speaker, our content expert today is Susan Stellan, public health researcher, educator, and communications consultant. This webinar is sponsored by the Northeast and Caribbean MHTTC. We are funded by SAMHSA to enhance the capacity of behavioral health workforce and to deliver evidence-based and promising practices to individuals with mental health conditions. We are also address the full continuum of services spanning mental illness prevention, treatment, and recovery supports. And we also train related workforces such as police, first responders, primary care providers, vocational service professionals, etc., to provide effective services to people with mental health conditions. We also have supplemental funding to support school teachers and educators and staff to address student mental health and also support healthcare providers and wellness and self-care activities. Next slide, please. We just want to make you aware that we will be recording this webinar and posting it on our website along with the presenter slides and any relevant resources within a week of today. Throughout this webinar, we'll be using the Zoom chat feature located on the taskbar below to respond to questions. So please feel free to raise your hand during the Zoom option if you'd like to speak during the Q&A portion of this webinar. Next slide, please. This presentation was prepared for the Northeast and Caribbean Mental Health Technology Transfer Center, or MHTTC, under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, or SAMHSA. All material appearing in this presentation, except that taken directly from copyrighted sources, is in the public domain and may be reproduced or copied without permission from SAMHSA or the authors. Citation of the source is appreciated. We ask that you not reproduce or distribute this presentation for a fee without specific written authorization from the Northeast and Caribbean Mental Health Technology Transfer Center. This presentation will be recorded and posted on our website. Next slide, please. We just want to remind everyone that the MHTTC network uses affirming, respectful, and recovery-oriented language in all of our activities and products. This is language that is strength-based and hopeful, inclusive, and accepting of diverse cultures, genders, perspectives, and experiences, language that is healing-centered and trauma-responsive, and invites individuals to participate in their own journeys, language that is person-first and free of labels, non-judgmental and avoids assumptions, and language that is respectful, clear, and understandable, and consistent with our actions, policies, and now at this time, I'm going to turn it over to our speaker for today, Susan Stelling. Welcome, everyone.
Great, thank you, Kathy. I just wanted to acknowledge a question in the chat. Yes, everybody's muted today. It's a webinar format, but just encourage you, if you have questions, I'll be monitoring the chat and Kathy will be helping me. But, we do have the option if people are in places or feel comfortable speaking, that's fine too. So I think just using the chat feature, but you don't have to worry about being muted. So just a little bit about me. This is actually the second part in a kind of a series, so some of you may have joined that first one. I had a long career in journalism and teaching media ethics and went back to school to study public health in 2017. So since then, I've been working on projects to reduce overdose deaths, educate people about substance use disorders, improve access to treatment and harm reduction services, and support people in recovery. So I've been facilitating training workshops on all of these topics and try to present a wide range of perspectives. And you'll see today there's a lot of slides, you'll get copies of them, but really try to take a visual approach to learning and engagement here. I often collaborate with my husband, Graham McIndoe. He's a photographer who's been open about his history of addiction, incarceration, and recovery. So that definitely motivated the work that I do and, my experiences throughout his trajectory. And, you see a couple, we've done lots of exhibitions and kind of public art, really trying to engage people and kind of highlight quotes from interviews as well as photographs of people who've both, worked in the field as well as received services. So today's topics, the first part really talked about, kind of using some of that background in media, thinking about, where we learn about substance use, addiction, treatment, harm reduction, and recovery, and sort of the sources of information that shaped our views. Shifting now to kind of talking more about current drug use trends and changes in the drug supply, and particularly this shift to synthetic drugs. We'll talk about opioid and stimulant overdoses and how to reduce risks, the prevalence and effects of non-fatal overdoses. Sometimes that gets overlooked a bit, starting to be more research on that. How to respond to an overdose and where to obtain naloxone. That'll be a review for some of you. Great to get training on that if you haven't had specific training. And then finally, what protections are offered by Good Samaritan laws. But again, please feel free to ask questions in the chat and I'll be monitoring that. So this gives an overview of some of the topics I'm going to go into in a little more detail, but polysubstance use is common. So people tend to use multiple substances, often mixing prescription medications, alcohol, and other drugs. The potency of many drugs has risen. I'll be showing some slides about that, so including for cannabis and methamphetamine. Plant-based drugs like heroin are being replaced by synthetic drugs made of chemicals that are easier to ship and have higher profit margins for sellers. And the drug supply is certainly more lethal, especially due to fentanyl, a powerful opioid that may be mixed in with other substances, which can include cocaine and other stimulants. Xylazine, which is also known as tranq, an animal tranquilizer, is also being combined with other drugs. And finally, drugs are more widely accessible, in part due to technology making purchases and delivery easier. And there are also more prescription medications in many homes. So when we talk about overdoses and particularly non-fatal overdoses, it's not just the illicit drug supply that's impacting that, but, also prescription medications and then alcohol mixed in sometimes. So lots of text on this screen, but, really kind of looking at what we mean when we talk about polysubstance use. And there's more research effort to try to define that and understand that and figure out how to study it. But, certainly there's widespread agreement that that's more common. And it includes when two or more substances are taken together or within a short time period, either intentionally or unintentionally. So it's kind of important to make that distinction. Intentional use of more than one substance, might be when someone takes a drug to increase or decrease the effects of a different drug or wants to experience the effects of a combination. Unintentional polysubstance use can occur when the person takes drugs that have been mixed or cut with other substances, for example, fentanyl, and might not know that it's in there. In 2019, 50% of drug overdose deaths involved multiple drugs. There's a screenshot from the CDC's site, probably more, in recent years that I would suspect that number has gone up. This slide also highlights prescription drugs, noting that the dangers of mixing those drugs with other substances or even multiple prescribed medications can also increase overdose risk. So I'll be showing some statistics about that. And this just kind of illustrates what's being found, not just in, the toxicology reports that happen after someone has a fatal overdose, but also kind of in drug testing. So this was an article in the New York Times, that shared toxicology lab results. A street medicine team in Michigan had shared that with the reporter. So, you can see that there are a lot of different substances coming up in those toxicology reports. And, often that is the case that, whether it's lab testing or, after an overdose death, many substances are being found. And important to note that sometimes it really depends on how many substances are being tested for. So, you can't assume that just because something isn't necessarily listed that might not have been in someone's system, because not all coroners test for all substances or even all toxic screens that are happening, outside of the context of an overdose death. Any questions so far? Still welcome people to add to the chat if you have any. So this slide shows the potency of marijuana or cannabis and how much it's gone up. So, this is the average THC percentage of cannabis samples seized by the Drug Enforcement Administration. So important to note that that's a specific sample that, are things that the DEA has seized, but still you can see that the THC percentage has really risen, between 1995 and 2020. And certainly, at dispensaries, there's been some discussion about how even what's on the label might not reflect the actual amount of THC in a particular product. But, when people say that marijuana or cannabis that's being used today is not the same as, what people maybe have thought about or used in the 80s or 90s, that's certainly the case there. At the same time, and we'll be talking a little more specifically about changes in methamphetamine, but this slide shows, again from the DEA, the methamphetamine purity in these two time periods. So, the early 2000s versus 2016 to 2019, and you see it goes from, starting on the left about 35% up to the high 90s in recent years. So that's a big shift that really affects, how people are impacted who are using methamphetamine. So just kind of as an exercise, using the chat, try to get you all to think about how many drugs come to mind. So, I'm asking here, please write in the names of different drugs that come to mind. In the chat box might be illicit drugs or prescription drugs people sometimes misuse. So, type your whole list and then hit enter on the chat box. Once you kind of, obviously you're not going to come up with a comprehensive list, but, just in one of those free associations, what comes to mind? Great, start to see a few responses coming in. Yeah, so a lot of people are naming one or two or three. If you kind of thought about a list or even thought about how many, you could name if you're writing it in your own notes. So starting to see more kind of come in here, that and kind of the point is, many of us have certain drugs that are top of mind, either from the work we do or personal experience. And at this point, that may not capture sort of the wide range of substances that are out there and that are either intentionally or unintentionally part of the drug supply. Great. Thank you. So, lots of different names there, and, people will see that what has been posted represents kind of a mix of substances. So this graphic kind of illustrates, it comes from, it's licensed through a Creative Commons license, but the drugs wheel. And, you can see that the outer ring shows sort of broad categories of drugs, so opioids or cannabinoids or stimulants or depressants. And then kind of moving in, it shows, and I know this is small, but more specific names within each of these categories. And in the very inside ring, newer psychoactive substances, I'll be talking about that phrase, that are appearing again within these categories. So, this group has kind of come up with different ways of visualizing it, but I find this kind of helpful to see or to illustrate a visual of kind of how many drugs are out there that kind of are frequently, or as you get to the inner ring, kind of less frequently, um, maybe described or talked about publicly. This is another source that kind of looks at what are called novel psychoactive substances, part of that shift to synthetic drugs, tracked by the Center for Forensic Science and Research and Education. So this is, points out that since 2018, this group has identified 240 NPS or novel psychoactive substances in forensic samples. Those opioids, stimulants, and cannabinoids are the broadest categories, represent the largest subclasses observed. In 2023, 79 in total were detected. So, some of the details here are a little less relevant than just the fact that there are a lot of substances out there, especially with things, that are being manufactured kind of, using chemicals and synthetically, and more are being discovered in all the time, and different, reports come out about dangers of different things. I see a question here, would Delta 8 be considered an NPS? That's a good question. I'm not sure if that's based on, what the time period is for something to be novel. I think it's definitely would be considered, in this category of drugs broadly that are emerging. But I think if you maybe looked at this slide, it's a little tiny print for me even here, but when you get the slides, you may be able to zoom in or find an answer using one of these sources. So, thinking about why this trend is happening, these are just some kind of broad bullet points of why synthetic drugs are becoming more common. They don't rely on cultivating plants, needing land, water, and other expenses. Lower production and shipping costs lead to higher profits. They're more potent than traditional plant-based drugs. They can be cut into other drugs. So, for example, replacing heroin with fentanyl. They can be pressed to resemble counterfeit prescription pills. So I'm going to show an example of, graphically representing how that happens and what are some of the risks it presents. And the chemicals used to make them travel across borders easier, and kind of, important to note too that many of these what are called precursor chemicals are used in other manufacturing processes too. So it's difficult for countries to ban them because they are used for other purposes in some cases. Any questions? Another factor too is how policy change can impact kind of these shift in drug markets. So, for example, efforts to reduce opioid painkiller prescriptions shifted some people to heroin use. In 2022, the Taliban prohibited opium poppy cultivation in Afghanistan, which reduced opium production by 95%, according to a UN report. That's impacted heroin markets and increased the use of synthetic opioids, certainly in some markets. In terms of methamphetamine, restrictions on ephedrine, which was derived from the ephedra plant and used for decongestants like Sudafed, contributed to increasing methamphetamine production using chemicals, including P2P. So, that's again a shift from something that had, more of a plant base to entirely based on synthetic chemicals or manufactured from that. So leading to that potency I described in the earlier slide. So what that led to is that these meth labs proliferated, prices dropped, and purity increased. So meth use has also risen, often by people who use opioids too. And some of these facts about fentanyl, these come from a CDC flyer, are probably pretty familiar by now. This is a synthetic opioid that's about 50 times stronger than heroin and 100 times stronger than morphine. That's become a major contributor to both fatal and non-fatal overdoses in the US. So, you still have two types of fentanyl, the pharmaceutical fentanyl, which is often used to treat severe pain, particularly after surgery or advanced stage cancer, as well as illicitly manufactured fentanyl. They're both considered synthetic opioids. Most recent cases of fentanyl related overdose are linked to illicitly manufactured fentanyl, which has been distributed throughout the drugs markets for its heroin-like effect. And some of the last points there we've talked about. I think this number has probably gone up from this flyer, but at the very least, over 150 people die every day from overdoses related to synthetic opioids like fentanyl. Yeah, and fentanyl is also a category. So carfentanil, sometimes they're referred to as fentanylogs, they're analogs of fentanyl. So carfentanil is an example of that, which yes, is stronger than fentanyl. And, there was a time, wouldn't guess at the time period where that was emerging, particularly in some Midwestern states like Ohio. So these drug use patterns and what's in the different drug markets does shift over time, but also can be different geographically. There's another question, I'm not sure what that references regarding kind of an increase in purity. I'm not sure which substance that refers to, if you want to clarify that. And so this is a graphic too that I thought was helpful to kind of illustrate the risk of counterfeit pills and sort of how, substances can be cut into other drugs. So, if you see that as the active substance, maybe that red or dark purple in the middle kind of represents fentanyl, and it's mixed in. By the time you get to the tablets, there might be one tablet on the left side in that lower area that doesn't have any of that substance that's been mixed in, while others, as you move to the right, have a little bit and then a little bit more and then quite a bit on the far right. So, this is what's impacting counterfeit pills sold as prescription medications like oxycodone, Percocet, Vicodin, can contain other substances in really unpredictable amounts due to how drugs are cut. So, when you see sometimes, people using substances that they have no idea, or tablet or pills that they have no idea that might contain something like fentanyl, this is kind of how that might happen and lead to an overdose death. And even people in the same group might not be impacted in the same way by taking different pills. So this is kind of a question, posing out there. People ask it a lot, why would traffickers and dealers add fentanyl to counterfeit pills and other drugs if the risk of death is so high? Any thoughts on that? If anybody wants to take a stab at answering. Yeah, because it's addictive and they'll want more, kind of to influence the market here. Not concerned about safety, looking kind of at profit. The revenue is higher if they can cut it with cheaper products. Yep, easier to get past the border. Increased demand for that. So if you start to get people, dependent on opioids who maybe weren't using any type of opioid before, yeah, as you see, it's not a precise process, especially where some of this drug mixing happens. So calculating the correct amounts. So this kind of gets at, I pulled this from different sources, but often it does come down to sort of the profits from fentanyl. So, that's become a strong motive for traffickers and dealers to produce counterfeit prescription pills or else to mix it in with other drugs. So, people could argue about sort of the numbers here, but with a kilogram of pure fentanyl, someone could potentially make more than 650,000 counterfeit pills using 1.5 milligrams of fentanyl per pill. So for many adults, a lethal dose is 2 milligrams of fentanyl. That can vary certainly based on your tolerance for opioids and many other factors. But if you think about, traffickers can typically purchase a kilo of fentanyl for less than $50,000 from a supplier, use it to manufacture hundreds of thousands of pills, and sell the counterfeit pills for millions of dollars in profit. So again, at the bottom here, prices vary, but if those pills are sold for $15 each, might be lower, the gross revenue could be nearly $10 million. So, you kind of see how, the ability to produce illicitly manufactured fentanyl, distribute it through the drug supply, and then sell it for, prices per pill or however the drug's particular substance is measured and sold, does lead to a high profit margin. Any questions or comments or thoughts? And if you're comfortable, if you're in a place and want to speak, I think if you raise your hand using the Zoom chat, we'll be able to see that, and Kathy can help kind of unmute you or create an opportunity to speak. So just moving on, many of you will be familiar with or have heard of xylazine, if not encountered in the work you do. That's not an opioid, but it is an FDA-approved veterinary tranquilizer, sometimes referred to as tranq or tranq dope. It's being added to illicit opioids like fentanyl, often to lengthen the euphoric effects of the opioid. Some of the impacts it can have is that it lowers blood pressure and respiratory rate, can induce loss of consciousness for hours. Importantly, Narcan does not reverse the effects of xylazine because it is not an opioid. But if you suspect an overdose with xylazine, you should still give naloxone or Narcan, because it may be that person is also, having an experience with opioids as well. Someone's mentioned seeing this in their clinic. You'll be familiar with kind of, xylazine can cause skin wounds with scaly dead tissue. It can be, the skin begins hardening into kind of crustier blackened tissue, and these wounds can become severe or progress in days. Untreated, if they get worse, this has also led to the need for amputations for some people. So lots of concern about xylazine right now, and it's kind of moved around the country and is more or less prevalent in different places. And again, just welcome anybody to make comments or add questions there. So some of you may also have heard about another class of opioids that's emerging in the US, also pretty prominent in the UK and other parts of the world, called nitazines. Some people pronounce it nitazines. And these are a class of opioid drugs that are up to 20 times stronger than fentanyl. So again, kind of going up the scale of, potentially being lethal. And, in fact, they've been identified in the US illicit drug markets. It's a class, so they're many dozens of or more than a dozen types of different nitazines, which have also appeared in Canada, the United Kingdom, and Europe. They were developed in the 1950s as a potential painkillers, but were never approved for medical use, partly because of this, potency and concern. Naloxone can help reverse an overdose involving nitazines, but multiple doses may be required, obviously, because of the strength of these opioids. Is this a type of drug that's anybody is familiar with or has encountered or read about? Just curious if you want to add to the chat. Yeah, someone's mentioning in New Orleans seeing it. I pay a lot of attention to the UK drug market, so I think more prevalent there. Yeah, some people are saying, just starting to hear about it. Great. And there was a summit last week where it came up a lot. And certainly in Canada. And then kind of moving into some other substances, I pay a lot of attention to different media sources too. So sometimes things kind of get media coverage before they're really, part of a research study that takes time to propose, get approved, conduct, write about and publish. So, here's another substance that's become concern, tianeptine, sometimes referred to as gas station heroin. It's an addictive drug at high doses, and it's being sold as a dietary supplement in gas stations and convenience stores. They can be contaminated with metals, microorganisms, or other undisclosed drugs. And just earlier this year, the FDA put out a warning saying, not to purchase Neptune Fix or any other tianeptine products because of serious risks, including seizures, loss of consciousness, and death. They can also interact in life-threatening ways with other medications a consumer might be taking. And, typically they're sold either in tablet or powder form in some of these locations. Sometimes smoke shops are certainly online as well. So, here are a couple links. You'll receive the slides that you'll be able to click on that to get more information about that. But, just a couple examples here illustrating kind of the proliferation of different substances in different types of locations. I'm seeing a question. So here's someone's asking, I think someone might be wanting to speak. So should I pause for that? Oh, that disappeared. One question is about nitazines. Are they showing up in counterfeit pills and cocaine like fentanyl is? I'm not sure specifically about cocaine there, but I think they are being mixed in with other substances, certainly opioids, and possibly maybe someone else wants to address whether that's pill form or in other places. Someone's kind of answering here. Tianeptine is a big issue where they're located, as well as there's debates about whether people pronounce it kratom or kratom, but someone had asked about it in the chat, and this is some bullet points from an investigation in Tampa Bay, Florida by the Tampa Bay Times. And kind of basic findings are, is that companies are selling the substance without dosing instructions, a list of ingredients, or sometimes any label at all. The majority of products that this investigative team had tested hadn't disclosed their intensity on labels. 9 in 10 people who had died, again, in this investigation, had a substance in their system that could be harmful when mixed with kratom, including common medications used to treat anxiety or depression. So particularly for this audience, a lot of mental health providers, important to know about these interactions that can happen between, things people might be taking. If you're a counselor working with people, you might not know. And yet they're also prescribed prescription medications for conditions like anxiety or depression. It's been marketed by companies as a safe way to escape opioid addiction, but people with a documented history of drug use accounted for the majority of kratom-only overdoses, again, in this investigation. So, people might have things to add to the chat kind of based on their experience in different parts of the country and what you're seeing. But, definitely this is on the radar of, many communities as something mixed with other substances. And depending on the purity level and the dose and someone's tolerance, can have serious and sometimes lethal effects. Any questions? Yeah, thank you. I think that was mentioned too, that it can also contain heavy metals and is pretty unregulated. So, what people are getting can be very unpredictable and unknown to them. So I wanted to also just touch on US prescription medication trends as sort of part of this discussion of sort of what's out there and what people are using and how things interact. And just a few bullet points from, this source that kind of tracks prescription medication data. And, the number of prescriptions dispensed through US retail outlets reached 6.7 billion in 2022. Prescription drug use trends tend to be based on age, gender, race and ethnicity, income and health status for different, drugs. One that's been talked about a lot, particularly coming out of the pandemic or in recent years, use of ADHD medicines grew 11% over the last 5 years, with women 20 to 64 years old now accounting for a third of prescriptions. And overall, mental health prescriptions have increased since 2019, with girls under 19 seeing a 33% increase in use. Per capita prescription opioid use is down 64% since the peak in 2011, but overdose deaths continue to rise, not necessarily again from prescription medications, but more so now from fentanyl and other illicit substances. So just to kind of show, these are kind of trends for specific types of prescriptions for different conditions. So, the second one listed there is mental health, up 4.3%, between 2021 and 2022. Pain, actually down a little bit there. Other CNS, so those would be central nervous system, respiratory depressants, 3.1% increase, and then ADHD, let me scroll along here, about a 7.5% increase. So, these are really broad categories, but really just kind of the point is to look at, or to consider prescription medications and, increasing use certainly as people get older. Women are prescribed medications more than men. So, that's part of the mix of substances that are out there that people are using. So kind of, I showed some of these slides in the first session, but just kind of wanted to review, this is past month substance use from the 2022 National Survey on Drug Use and Health. For anyone who's not familiar with that, that's conducted annually. Certainly was impacted during the pandemic, both the data collection and, some of the trends that were found through these surveys. And importantly, it does miss certain populations. So people who are incarcerated or in many other institutional settings. So, it's calculated to be representative, but, take that with it. There's a lot of asterisks if you download the full report there. And in this slide, the numbers or these graphs are not mutually exclusive. So someone, and these are numbers in millions, could be, using alcohol as well as marijuana as well as cocaine. But you can see here that alcohol use in the past month, about 137 million people aged 12 or older. Tobacco, the next highest category. Marijuana, 42 million, a little bit more. And then other substances, less on the left side there. And this is past year illicit drug use. So the other slide showed past month, and this is focusing just on illicit drug use, so not including alcohol. And that about 1 in 4 people 12 or older had used one of these drugs in the past year. So that does include marijuana as well as hallucinogens, misusing prescription pain relievers. So that would be, for example, if they weren't prescribed to you, you got them from someone else. Cocaine, tranquilizers or sedative misuse, stimulant misuse, methamphetamine about 2.7 million, and then kind of heroin is at 1 million. And just a reminder too that these aren't mutually exclusive, so people might be in more than one category. And this is a graphic, from some of the information put out with that survey that, illustrates past year marijuana use among people aged 12 or older. So, about 1 in 5 people in that age range had used marijuana in the past year, so a little over 60 million. And pulling kind of from another slide I wanted to add here, about 19 million people, or 6.7% of people in that 12 and older age group had a marijuana use disorder in the past year. And then this shows just on the bottom left, about 1 in 5 people aged 12 to 20 had used marijuana in the past year. And then 1 in 9 aged 12 to 20 had vaped marijuana in the past year. So these are, they've started putting out more graphics to go along with this survey data, different ways of presenting it. So that links to the source for that and some other graphics. We're starting to see more focus a little bit on kind of where people live in terms of population density. Sometimes that talks about, urban versus rural. This pulls out data that kind of doesn't just have that binary distinction, but sort of distinguishes between large metro, small metro, and then non-metro areas. And then within non-metro, you see there are these other 3 categories. So, you can see that patterns don't vary too much, based on where someone's located. You can see that in a large metro area, any illicit drug use is a little bit higher compared to non-metro areas. If you're wondering about patterns in rural areas, any use of opioids is a little bit higher in non-metro areas. and prescription pain reliever on the right here, higher in non-metro areas. And then, for marijuana use, a little bit higher in large metro areas compared to non-metro areas. And even for methamphetamine, which can be associated with rural areas, certainly there is a difference here, a little under 1% for large metro areas, 1.5% for non-metro areas, but, not largely significant in the differences between those percentages. But I think we're starting to see more data try to analyze things like overdose deaths, also based on where people live, and as well as the availability of services in different types of areas. Yes, someone's pointing out lots of meth use here in rural northeastern North Dakota. And so, often those patterns vary. Sometimes, certain drugs are sold based on, how trafficking works near highways or big arteries through the US. So that can impact that too. And certainly with methamphetamine, kind of more production and becoming easier in smaller kind of ad hoc labs, that's proliferated around the country as well. So this is a pretty open-ended questions, but wanted to ask, what are some of the physical or psychological conditions you've observed among people who use higher amounts of drugs or use drugs more frequently? This question may be more for people who are working in these service environments, but just kind of trying to get a sense of what, looking at those, yeah, obviously depends on the drug here, but anything. Yeah, psychosis, less satisfying relationships with others, might be irritability, chronic pain, connections with people who are unhoused, can affect sleep, anxiety, trauma, academic performance, some movement disorders. Yeah, it can affect cognitive things like memory, schizophrenia, great impact on mental health, more hospitalization for psychosis induced by substance. Everything. Thank you. Appreciate that. So I'm kind of picking out a few things here and kind of tried to find some data. I think this could be the topic for a longer workshop or webinar. And one of the things people have been asking about is kind of high potency cannabis use and its effects, or just generally cannabis use and its effects. So, um, and I started looking for data, and there was an effort. There's been a lot of data put out, and I think that the conclusion that a lot of researchers have drawn, that have tried to look at a lot of different studies and surveys, particularly as research opportunities open up with cannabis legalization in many areas. Evidence for an association between high potency cannabis use and mental health conditions such as anxiety, depression, and psychosis-like symptoms is mixed. So there's studies that find some impact, again, and this is focusing on high potency cannabis use as opposed to broadly any cannabis use. But, some researchers at the Colorado School of Public Health, they've been asked by the state legislature to review studies examining the physical and mental health effects, specifically of high potency THC marijuana and concentrates. They reviewed more than 450 studies and found limited or moderate evidence supporting the most common health claims about high potency cannabis and either beneficial or adverse effects. So a lot of this kind of leads to the need for high quality research on both the benefits and adverse health effects of cannabis. But this link here goes to the full report that these researchers in Colorado put out. There's also one for kind of an editorial in the journal Addiction that I think it's fair to say we're still learning a lot about this as use increases, and there are more opportunities to study that. But certainly I think anybody who is seeing some impact, particularly for certain age groups, sometimes with people with, who might have more of a predisposition towards some mental health conditions, starting to be more research about that. Looking kind of at stimulant use and effects, people, we've talked about methamphetamine. Most commonly used stimulants would be that and cocaine. Others can include ecstasy or MDMA and prescription medications. So cocaine has a shorter half-life than methamphetamine, so it's absorbed, metabolized, and excreted quicker. So that can be between 30 and 90 minutes, give or take. That can lead to more frequent use to get the same effect compared to people using methamphetamine. Important distinction is that cocaine inhibits the reuptake of dopamine in the brain, which means it's preventing it from being absorbed, whereas methamphetamine both inhibits that reuptake as well as increases dopamine release. So if you're working with people who use either or both and notice differences, that's an important distinction between how someone, the effects of both of those types of drugs. Stimulant use can improve attention and focus. That's a lot of reason why people use that or those types of substances, but increased use can also lead to mania, paranoia, delusions, hypersexuality, and other effects. And then withdrawal symptoms can vary based on someone's dependence, history of use, and other factors. They can be physical and psychological, including jitteriness, chills, hallucinations, intense cravings, depression, anxiety, body aches, impacted sleep, and fatigue. And some can last for weeks or months. Someone's asking in the chat, so yeah, so it's on the slide here, but if you're not able to see that, about how the difference between meth and cocaine in terms of affecting dopamine. And so they both inhibit the reuptake of dopamine in the brain, preventing it from being absorbed. Meth also increases the release of dopamine, so it has a more powerful effect in terms of the dopamine. So everyone will get these slides, so you'll be able to look at that in more detail. So kind of shifting to overdoses here, some of this will be a little bit of a review, but also wanted to distinguish between, opioid and stimulant overdoses. But broadly, overdoses happen when a toxic amount of a drug or a combination of drugs overwhelms the body. So for an opioid overdose, that's when large amounts of opioids, sometimes with other drugs, cause breathing to slow or stop. Opioids fit into receptors in our brain that also affect the drive to breathe. So what happens is oxygen levels in the blood decrease, eventually stopping other organs like the heart and brain. This can lead to unconsciousness, coma, or even death. Stimulant overdoses, so from drugs like speed, methamphetamine, cocaine, ecstasy, raise the heart rate, blood pressure, and body temperature and speed up breathing. That's sometimes called overamping, and it can lead to a seizure, stroke, heart attack, or in some cases, death. So this graphic, shows the increase in drug-involved overdose deaths. So that's all types of overdose deaths between 1999 and 2021. Data has come out for 2022, increased again to almost 108,000 drug-related overdose deaths, which is about 300 people a day. And you can see here, the differences in terms of gender. So, men are this yellow line here, males versus females, the red line there. So males more likely to have a fatal overdose death. I'm going to show a different pattern when we look at one source of data for non-fatal overdoses. And this shows shifts kind of over time with all drug-involved overdose deaths between 1999 and 2021. And these may be a little harder to see the colors of these lines on Zoom, but the top one in gray is synthetic opioids other than methadone, so primarily fentanyl really increasing. Psychostimulants with abuse potential, primary methamphetamine, that yellow line also increasing. Cocaine, the red line there, as well as prescription opioids in blue, benzodiazepines in green, heroin, different color blue, and then antidepressants at the bottom. So those would be substances that were implicated in that overdose death. This is another way of looking at overdoses and the overlap between, opioid and stimulants. So the top line is all overdose deaths involving stimulants. The green line is stimulants and opioids. So the top line would include both of these below. And then the blue line at the bottom is stimulants and no opioids. So even without opioids, this illustrates that kind of the stimulant deaths or overdose related fatalities related to stimulants are also increasing. Any questions?
I see a question in the chat. Someone would like to have the ways in which meth versus cocaine affect dopamine repeated if you can.
We did that one. You can see there the response. So yeah, I repeated that, but it will be in the slides too here. And this comes from some information that came out pretty recently looking at the average annual number of deaths from excessive alcohol use over this time period, 2016 to 2021. So illustrating this, partly because we can focus a lot on drugs or illicit substances, but, sometimes overlooked or less focused on is sort of the impact of alcohol use on health and well-being as well as kind of longevity. So deaths from all causes related to excessive alcohol use in this time period. This is actually for both of those years. So, 178,000. So if you click on this link, you can kind of see the breakdown of kind of what's included, but, here on the slide, you see that deaths from excessive alcohol use includes all deaths that were attributed to conditions that were fully caused by alcohol use, alcohol-related acute causes of death that involved binge drinking, and alcohol-related chronic conditions that involved medium or high daily drinking levels. And you see, what's considered medium or high is different for men and women in according to these statistics. So this 178,000 number annually that's been in the media a bit recently, you can break down into chronic causes, which might be, cancer, heart disease and stroke, liver, gallbladder, and pancreas related illnesses is about 117,000 out of that 178. And then the acute causes, which could be alcohol related poisoning. And then motor vehicle crashes or suicide, 61,000. So this link has much more detail about this research and these statistics, but just kind of trying to point out what do they attribute the increase to? I think the CDC data, doesn't necessarily, cover that, what the why is on that, other than kind of pointing out the increases separately for some of these health conditions. If you look at the National Survey on Drug Use and Health, I believe that illustrates some patterns in alcohol use, but broadly, excessive drinking as it's defined, binge drinking is increasing, particularly in certain age groups. Older adults have higher drinking and sometimes more risky drinking patterns in recent years. So those are some of the, I guess, trends that, I've heard about, identified it related to alcohol, but others might, I think increase in risky use or that excessive use or binge drinking use would be the thing that would lead to some of these deaths or health harms, as well as mixing with other drugs, other substances. Kind of shifting a little bit here to non-fatal overdoses. Starting to be more efforts both at state and federal levels to collect data about non-fatal overdoses, but fair to say that there are many more non-fatal overdoses than fatal overdoses. Maine is a state that puts out data monthly, tracking that, and in 2023, fatal overdoses in Maine represented just over 6% of all overdoses, and that was a little lower than about 7% in 2022. So you can see that, the data on overdose fatalities is only capturing a fraction of all overdoses. People who survive an overdose are more likely to experience a fatal overdose. We'll talk about that in terms of risk factors. Opioids are the most common substances typically found in non-fatal overdoses. starting to be more research looking at the effects of non-fatal overdoses, but certainly can cause brain injuries, neurocognitive impairments such as memory loss, and physical effects such as heart complications, particularly people who experience several or more overdoses. And this, in terms of surviving an overdose, some research suggests that naloxone administration rates and overdose survival rates may be lower in less populated counties, due to potentially availability of naloxone or, just sometimes people using alone, or we'll talk about risk factors again, and in more isolated situations. This is something that struck me when I first heard about it a few years ago. Important to put it in context. So this is a company that analyzed, private healthcare claims. So looking at claims data for privately insured patients, including some Medicare Advantage enrollees, but not participants in Medicare Parts A, B, and D, Medicaid, or people who are uninsured. So broadly, mostly people with private health insurance, as well as some Medicare Advantage enrollees. And in every year that they analyzed, males accounted for 62 to 63% of patients with a substance use disorder diagnosis, yet females accounted for 60 to 61% of patients with an overdose diagnosis. These again are not necessarily fatal overdoses, and these would be overdoses that someone sought care or they resulted in some kind of insurance claim or healthcare claim. So it's not broadly representative of the entire population, but just interesting to kind of note that, as you take different populations and use different data sets, you can kind of see different patterns. Among patients who had a substance use disorder or overdose diagnosis in 2021, so again, interacted in some way with the healthcare system that resulted in a claim, 65% had a pre-existing mental health condition. Generalized anxiety disorder and major depressive disorder were the two most common mental health diagnoses that got cut off in this population. So they analyzed 6 years of claim records and found, 1.6 million, a little more patients had an overdose diagnosis, again, not necessarily fatal, which was an average of nearly 279,000 overdoses a year. So a different data set than many people maybe come across, lots of caveats on, who's included and who's not, but, some important numbers that kind of highlight some things about non-fatal overdoses that I think are important to note. And this is kind of just another graphic representation of, percentage of patients with an overdose diagnosis by gender in these time periods. And you see that the pattern, skews female. Some reasons for that might be, women are more likely to seek healthcare in general, might be due to some overdoses involving prescription medications, which women are more likely to be prescribed than men typically, but just a pattern to be aware of from this data set. Another one that kind of struck me was this came out from the U.S. Department of Health and Human Services Office of the Inspector General, and looking at Part D beneficiaries, so Medicare beneficiaries. So about a little over 50,000 experienced an opioid overdose from prescription opioids, illicit opioids, or both during 2021. The report notes this number is likely higher and that additional beneficiaries could have overdosed but not received medical care that was billed to Medicare. And that was an increase from 43,000 in 2020. So, this would be looking mostly at a population 65 and older, as well as some people who receive Medicare, due to disabilities. So, looking at that age range kind of pulls out a trend or a number that people might not have encountered before. The number of Medicare Part D beneficiaries who received opioids in 2021 decreased to almost a quarter of beneficiaries. So that's kind of continuing what's been a downward trend. And fewer were identified as receiving high amounts of opioids or at serious risk. Over 1 million Medicare beneficiaries had a diagnosis of opioid use disorder in 2021, and fewer than 1 in 5 of them received medication to treat their disorder. We'll be looking at treatment in a future, workshop as part of this series. This also notes that, more people in this group were receiving naloxone, so that's obviously a positive trend. Any questions? Both links to these sources are in the slides here, which you'll receive, so you can spend some more time looking at that if these kind of data or populations are interest. So kind of moving on to overdose responses and risk factors here. Just wanted to get a sense, if you can answer in the chat, if you've participated in a training to learn about overdose risks and how to use naloxone. Great, so a lot of people, yes. A few no's. So some of this will be a review, but great to see so many people have had training. Also be sharing some sources to get that training if you haven't had it. So for those of you who have said yes, what are some risk factors for an overdose? Anything you want to share in the chat? Okay, so the risk factors would be the things that could lead to an overdose, not necessarily what the effects of an overdose are. But yeah, so polysubstance use, using alone, after someone's been released. I'm going to go over some of these. Great, thank you for sharing here. So the risk factors for an overdose, tend to focus on kind of substance use patterns people have, previous overdoses. Great. So these are the things that are typically identified as overdose risk factors. So mixing drugs, as we've been talking about, creates a very big risk, when people mix particularly heroin or prescription opioids or fentanyl with alcohol and or benzodiazepines like Klonopin, Valium, or Xanax, that can increase overdose risk. Change in tolerance. So someone had mentioned, people who are released from prison or jail, your body's ability to process a certain amount of drug can decrease rapidly after a break from using. So, that can increase your risk of an overdose. Someone who returns to using after stopping or lowering their use for a while. The strength and content of drugs, so that potency that we were talking about. Street drugs often contain other drugs or materials that can be dangerous, including fentanyl. People have mentioned using alone. That can increase the chance of fatally overdosing because there is no one there to help administer naloxone or call 911. And then a previous non-fatal overdose. So I mentioned that people who've overdosed before are at higher risk for another overdose. And just to kind of highlight prescription medications again, some more bullet points here, but mixing prescription opioids with alcohol and or other depressant medications like benzodiazepines and tranquilizer can greatly increase the risk of overdose. Studies have found increases in overdoses involving benzodiazepines, which is often prescribed for anxiety, as well as gabapentin. So some doctors kind of shifted to prescribing gabapentin as opposed to opioids. And there have started to be a pattern of kind of increasing, overdose data finding gabapentin in the mix. So, that's a medication that can be used to treat nerve pain. The CDC has warned about the risk of overdose when gabapentin is taken with other central nervous system depressants like opioids. And just in terms of just kind of general advice about health officials encourage securing medications at home and making a plan to dispose of excess medications that aren't used, for example, returning them to a pharmacy. Any questions? So this shows a little bit more specific data about trends in non-fatal and fatal overdoses involving benzodiazepines in this time period. So between 2019 and 2020, benzodiazepine-related overdose visits per 100,000 emergency department visits increased, by 23%, both with and without opioid co-involvement. So, even these visits without opioids have been increasing. And in this period from, say spring 2019 to that same period in 2022, prescription and illicit benzodiazepine involved overdose deaths increased 28, almost 22% and over 500% respectively. So certainly much higher for these illicit benzodiazepines, which are sold, both through the street and online, definitely lots more places that people can get those. And during January through June 2020, almost 93% of benzodiazepine involved deaths also involved opioids, and 67% involved illicitly manufactured fentanyl. So highlighting this, the risks really increase when people are mixing illicit substances, prescription medications, and certainly, some of the higher potent substances like fentanyl. And Katie's just reminded people in the chat, if you want to use the raise hand function to request that your microphone be enabled, feel free to do that if you have a question or comment as well. So this will be a review for many people. Never hurts to go over it again, but these are some signs of an overdose. So, loss of consciousness, or someone might become unresponsive to outside stimulus. They're awake but unable to talk. Breathing can be slow, shallow, erratic, or maybe has stopped. For lighter skinned people, the skin tone can kind of turn blue or purplish. For darker skinned people, it might be more gray or ashen. Someone could be making choking sounds, a gurgling noise, or vomiting. Fingernails and lips turn blue or purplish black, and their pulse or heartbeat might be slow, erratic, or not there at all. So the next question is, what are some strategies people can use to reduce their risk of an overdose? Harm reduction broadly, we're going to focus on what different tools exist within that harm reduction umbrella. What else have you heard, or what within that harm reduction realm would you say? Drug testing strips, great. Never use alone hotline. I'm going to talk about both of those. Using with other people, great. So these are kind of broadly having a Narcan. We've caught a lot of them here. So, certainly carrying naloxone to reverse an overdose and knowing how to use it, avoiding mixing drugs, including alcohol. Here's a number for that Never Use Alone hotline. If you haven't heard of that, there's more information on the Never Use Alone website. But broadly, this is a number of people, if they're in a situation where they don't feel comfortable using around other people or can't, they can call this hotline. They'll be asked to give their location, and if they become unresponsive during the call, that person will call 911. The person answering the call will call 911 and, report that, someone has become unresponsive in that location. So, that's a great resource to promote within the communities you work in. Certainly testing drugs with fentanyl or xylazine test strips, both exist now. I'm going to talk about some sources or where you can find those if you don't know of a local source. Great. Someone's kind of talking about, the next, talk about the next training in this series. We'll be focusing more on a range of harm reduction tools. So this is just a quick review of responding to an overdose and using naloxone. So, it's a safe medication that can reverse the effects of an opioid overdose. So, it works on opioids like heroin, fentanyl, and prescription painkillers, but it's safe to use even if you aren't sure if opioids are present. So you'd always want to check for responsiveness before giving it. That might be shouting in the person's ear. If you don't get a response, grinding your knuckles into their breastbone, referred to as a sternal rub. If you're not getting a response, it's definitely an emergency situation. You'd want to call 911 and tell them someone is not breathing, so you get that backup support. And then give naloxone if you have that. This illustration shows the nasal Narcan type naloxone. And, simple to use, putting it in the nostril and pressing the plunger at the bottom. And, if there isn't a response in a couple minutes, you'd want to give a second dose if that's available. this just reiterates that, it can also be important in certain situations to give rescue breaths or CPR if you know how to do that. Kits often contain a face shield. And you'd want to put someone in the recovery position, whether after you've given naloxone or rescue breaths. And this is important to prevent choking. Important also to stay with a person until medical help arrives. That's because naloxone typically works for 30 to 90 minutes, and it can cause withdrawal symptoms until it wears off. For that person, using more drugs is unlikely to reduce those withdrawal symptoms because of the naloxone will still be in their system, but using drugs can increase the risk for another overdose. Naloxone is available without a prescription in any U.S. state, Washington, D.C., and Puerto Rico. Check with your insurance company to see if it's covered. You can also get it at many pharmacies, or can often get it for free from your state or local health department and community-based organizations. So one source for that, or to find out where it's available, some of you may have heard of this organization and site called NextDistro, but one of the great resources that they offer is a tool listing, what you can find in all 50 states. So, this button, select your location, includes information about where to get naloxone, find overdose education and training, and connect with harm reduction and some treatment services as well. So just to show an example, for New Jersey, if you clicked on New Jersey on that site, it would show, how you can request naloxone and fentanyl test strips by mail, which pharmacies, a link to find out which pharmacies are participating in New Jersey's Naloxone 365 free Narcan program, where to find a local syringe service program, which typically offer other health and testing services and connections to treatment, a link to a calendar of naloxone and overdose response trainings in the state, and information about Reach New Jersey, a 24/7 hotline for support from trained addiction counselors, as well as a lot of other resources. So, what they list very straight by straight, but broadly, these graphics kind of represent the different categories. Any questions? Comments? This is, again, the NextDistro site. You could choose New York, you could choose the state that you're in. Most state health departments also have other resources. So, just pulling some, information about New York State, since many people joining today are either here in New Jersey. New York State has more than 2,600 pharmacies that provide naloxone without a prescription. If you have insurance that has prescription drug coverage, New York has this NCAP, or naloxone copayment assistant program, that will pay up to $40 toward the cost of a copayment for naloxone. If you go to this link here, on the bottom left, you can find out more about that program and find a pharmacy that has naloxone. Includes a lot of the major chains that are near many people in the state. And, the state also has a calendar of community opioid overdose trainings that are in person and online. Review in more detail some of the things that I just went over, but broadly, how to respond to an overdose and administer naloxone, where to get naloxone, and I'm going to be talking about the protections of what are known as Good Samaritan laws shortly here. But these are just kind of illustrating, I saw this billboard in northern Michigan. So great to see that these resources are being promoted, so there, if you went to that site, and /Michigan, as you see on the billboard, you'd get right to the page listing resources in that state. This is a photograph of a vending machine in Dunkirk, New York. Starting to see more vending machines. Not, sometimes groups are using those kind of small boxes that were previously used to distribute, newspapers or community newspapers or other ways of putting naloxone in areas. They're referred to as vending machines, but free supplies for people often have naloxone as well as other, test strips, and, restock those. So basically trying to make them available in places and situations, 24/7. So, people who may not be able to visit a public health department or a harm reduction or other community group have places to access them. Sometimes they're placed, I've seen little boxes near bars in different places, as well as just kind of growing number of locations. And wanted to kind of wrap up here, just kind of acknowledging Good Samaritan laws and how they impact, people's response or concerns about responding to an overdose situation. So you might have heard this phrase, many states have acted what are known as Good Samaritan laws that create immunities or other legal protections for people who call 911 in the event of an overdose. The point is to encourage people who might not otherwise be willing to call for fear they might be arrested for drug-related crimes. Lots of caveats to this. State laws vary. Some states have comprehensive laws that provide broad protection, while others have passed laws that consider seeking medical assistance for a person experiencing an overdose as what's known as an affirmative defense or a mitigating factor during sentencing. So, you see the state map here and some links to different places. One link goes to New York's law, the other goes to a page where you could choose your state and find out details presented in a lot of different ways for the state that you're in. And I believe, most states except for Kansas and Wyoming, and I think one of those two was either reconsidering passing a Good Samaritan law, but most states have some form of law. There's also a trend toward, passing legislation that, punishes people who, might have been involved in use of fentanyl or selling fentanyl or sharing fentanyl in certain situations. So, there are still concerns for people about responding to an overdose in terms of calling 911, which is why it's so important to kind of increase access to naloxone, particularly for people who use drugs or people who are around those populations. Any questions, comments about anything I've shown or experiences with Good Samaritan laws in your area or concerns you hear from people you work with or participants? So we still have time for questions. And again, if you raise your hand using the Zoom feature, or you have a comment, you can, we'll unmute for that. Again, this is in a series, and if you missed the first one, can't tell you offhand the first date we did, but it's, these are the recordings are posted, the slides are posted. And the next one will be harm reduction principles, strategies, and benefits. That's going to be 2 weeks from today at the same time. We'll go into more detail about harm reduction strategies, including syringe exchange, but also more broadly thinking about harm reduction as an approach that, can apply to a lot of people, including young adults or people who are using drugs, more sporadically, not necessarily people with substance use disorders. And then how harm reduction services can connect people to other types of care. So there's a link there in the chat so that'll be actually so 2 weeks from now on Wednesday, April 24th at 11 a.m., same time. There's a link for that. And then we're going to add a couple links to a couple surveys here to the chat. If you have your phone handy and like using QR codes, as part of the SAMHSA funding, it's, important to collect, feedback about these trainings. So if you can fill out the survey now, that's great. I believe you'll also be sent a link. There's some information in the chat here. A link for follow-up questions that you can email, pointing out that you'll be emailed a certificate of completion and a link to download the slides and view the webinar recording within 7 days. You can download the slides and a certificate of completion and submit them to your credentialing agency if you're trying to get continuing education credit for this. Great. So I'm going to stay on and, we'll show a second survey in a minute here for some upcoming work, but really appreciate everybody joining today and your participation. in addition to this survey link, there's another one that the MHTTC is conducting to increase perceived needs of mental health providers in delivering services and supports to individuals who are blind or visually impaired. And there's a link to that survey. If you participate or if you complete it, you can be entered in a raffle to win a $25 Amazon gift card.
Thank you, Susan, so much for presenting this wonderful wealth of information. It's extremely useful and very necessary in today's climate. As Susan had mentioned, I have shared in the chat box links to our surveys, as well as information on our certificates, recordings, presentation slides. So all of that will be available within 7 days of the recording, and it will be emailed to you. Please check your spam or junk folders, email folders for the links. Sometimes it might end up in there. But again, my contact information or our general email contact information has also been included in the chat box. If you have any other questions at this time, we can enable your microphone so that way you can speak and you can ask Susan a question yourself. I do see a lot of responses. Thank you so much in the chat. Susan, you have so many wonderful accolades here in the chat, and we really appreciate everyone's participation throughout this webinar. At this time, I'm going to pause the recording or stop the recording so that way people can, if they'd like to stay on and ask any questions in case they don't want their voice or question recorded. So I'm
Great. Thank you, Kathy.